Well, thank you so much for a really warm welcome, and I've had a chance to spend the last few days in Dublin. This is my first time in Ireland. I've traveled extensively, but I've actually never been to Ireland. I was joking with someone that it's sort of like Michigan. If you know anything about the United States, Michigan is at the top of the map. We call it America's high five. But it's not on the way to anywhere. So we don't get as many visitors, which is a shame because it's a lovely state and I would welcome all of you to come and explore it. But I said to someone in Ireland, I've just never passed through Ireland. And I was thinking that's probably how people think about Michigan. So I'm really excited to be here and to talk to you about design thinking. As Darren mentioned, and as I had a chance to talk to some people at Health Research Board yesterday, my firm specializes in planning. We mainly do strategy, operations, and facility planning for large systems. We'll do small hospitals, and we'll do projects with universities or with small colleges. But mostly our focus is the large academic medical centers, both in the United States and in Canada. So some of what I'm going to talk to you about today is going to be examples of how we used and applied design thinking in those settings. But I will be here for both days, and if at any point you want to talk to me about something specific or how you could use it in your work, I'm happy to talk about that. And I've used it in clinical trial design, in subject recruitment, challenges, things like that. So if that's relevant to you, or in any kind of policy making or evaluation work, we do a lot of that too. And design thinking is often very helpful in those formats, especially at the beginning of the process when you're really trying to form a deeper understanding. So I'm going to give you a whirlwind tour of pieces of it. Now, later, Peter and Trevor are going to take you deep into it. So I'm going to stay up at a higher level of maybe how we use it and what we use it for, and then they can actually work to teach you how to do it. So that's our roadmap. And I often like when someone tells me exactly what they're about to tell me. So for those of you in the room who like to work that way, I'm going to talk to you about how to ship a bike. Very important information. And it's sort of an interesting little story that then I'll tie together to explain how we think about design thinking as a framework in sort of life approach. That's how I think of it, thinking about what goes on here. Then we're going to talk about wicked problems and the role of wicked problems and why design thinking and other innovation methodologies perhaps are our best chance at solving them. And lastly, I'm going to talk you through two specific examples and then give you some tips for things that we did when we didn't feel like the framework went far enough for the problems that we were trying to solve. So I'm starting with this story because I think it's an interesting story of innovation in an unlikely place. This Dutch bike company, they do electric bikes, urban bikes, and I will make all my slides available, so don't feel like you have to write anything down. So this is a Dutch company that ships very expensive urban electric bikes. They're 2,000 to 3,000 euros each. I don't know if you're familiar with them. I actually wasn't very familiar with them. This company got a ton of press in the United States, not in Cyclist magazine, but in Fast Company. And they were actually very disappointed that they got this exposure because they were shipping these bikes worldwide. And what they were figuring out is that when they shipped them to the United States, there were all sorts of problems. And people would get them and they would call and say, my bike arrived, it's a mess, it's broken, it needs to be returned. And they would say, please send us photos of the boxes. And the boxes were just destroyed. So the founders sat back and they said, well, this is an interesting problem. The structure of the bike is right. The process is correct. We're putting it together right. We're putting together our shipping crates. They're the same protection that every other country is getting, and we're not having these problems in other countries. So what could this be about? Why is the outcome so different in the United States? And what they ended up doing is they sat back and said, well, what could we do to make people be more careful with our parcels? And what is it about the United States that makes this so different? And how can we really focus on what Americans love to solve the problem? So they went very deep into American psyche, and they figured out that if they made it look like a flat screen TV, people would be careful with it. And it worked. So they were actually very disappointed when Fast Company launched the story and then CNN and everyone else picked it up because they said, you're going to blow it for us. The whole point is that we trick people into thinking there's a TV in the box and then they're careful with it. But in fact, this actually worked. And the moral of this story is really that when we ship an expensive bike, and how they solve the problem really has nothing to do with the bike or the packaging. It had to do with understanding the cultural context within which this problem needed to be solved. And if you think of it in the structure, process, outline format that I just shared with you, we can apply that as sort of the backdrop for some of the health services research and health services work that I'm going to talk to you about today. They framed the problem, they tried to understand the situation differently, see it from a completely different angle, and then they tested different ideas, and ultimately the one that worked was the one that was responsive to the very specific context of the problem. So what does it have to do with healthcare? Well, I think we can use this sort of framework and this sort of questioning to get to a different answer, because we all share actually a lot of the same problems, and we know how to solve them. I mean, if people asked you, how do you fix the Irish healthcare system, many of you would probably have many ideas that if someone would actually implement or listen to you, they would probably work. And that's how we feel in the United States as well, barring our political situation, which is a little tough right now. But we do believe we know how to solve the problem if people would listen. So I'm going to start by telling you about, I actually refer to this gentleman, Dr. Vadas Donabedian, as a mentor, although I never had the chance to meet him. But he has such a strong legacy at the University of Michigan in the School of Public Health as the grandfather of health services research. And Donabedian was born in Lebanon, and he was born to, his father was a physician. He has a long history of physicians in his family. His son actually is a physician as well. And his family immigrated to the United States, where he then, he did not practice medicine in the United States. He went to Harvard, to the School of Public Health, where he focused on health services research, ended up with a master in public health from there, and then went to the University of Michigan to teach and to write and spend his scientific career there. So Donabedian was he was a very objective scientific thinker in his career, and he was known for the structure, process, outcome format that we use to evaluate medical care, and that actually the World Health Organization and others have since adopted as a universal, like, international standard for evaluating medical care. They've also added different components, but the original 1966 article, which is the most cited article that Milbank Quarterly has ever published, gave us the structure, process, outcome format. I just showed you how you could use it for something completely unrelated to healthcare, but the way that he did it was unique at the time and was the first framework that people gave that really made people think about how we research something like health services, which has so many different dynamics and complexities. One of the things that people don't remember so much about the original article is that the very last paragraph said that objective science is not enough. And somehow that gets left out of the story. But we spend a lot of time thinking about that, because what he said at the end of that article was, going beyond objective science, we need to actually understand where we are within the complex problems that we're researching. And that more, instead of saying, how do we fix this, or what is the solution, we should step back and say, what goes on here? And just objectively just sit and take it all in and understand the full context and complexity of the situation. So fast forward to 2000, Donabedian spent a lot of his life with prostate cancer and dealing with the complications from that, and spent the last couple years of his life in treatment at the University of Michigan Cancer Center, which is very well known in our country, very well respected. And in 2000, a health affairs editor interviewed him. And this article is available. It's a Health Affairs 2001 article, even though the interview was done in 2000. And I find it to be a fascinating article because I'm someone who's followed Donabedian, and I wanted it to be so much that it didn't end up being. They asked, this gentleman asked him about his legacy. And do you feel like your work has been done? And have you been treated in the way that you had hoped and that you had taught administrators and physicians and others? And it's several pages long and definitely worth a read if you're interested. But essentially what he says is that his care has been completely fragmented, the communication's been horrible, and that there are many parts of it that he would not describe as high quality at all. And it was very disheartening, but he has different positive messages within it, one of which is if people actually listened to all of the people within the system, we could probably fix it. And if people listened to patients and their perspectives, we could probably fix it. And it all went back to his what goes on here and understanding the players in the system and how to fix it. So you can use his framework on small problems, but you can also look at really, really large problems. Wait times, some people think are small problems. I put wait times as a wicked problem. Wicked problems, which are uniquely designed to be solved by innovation frameworks and things like design thinking, are those problems that we have just begun to accept. We just accept them as how things are. And people stop working on them because they just expect that that's just how they're always going to be. Excessive wait times, I would put as a wicked problem. Access problems, for sure. How do we get people to make healthier decisions? We have all the information. They have all the information. People know that smoking will kill you. They do it anyway. That is a wicked problem. So people want to give up. They just want to say, I don't want to work on this anymore. We have to work on it. These are the wicked problems that once we solve, we'll have really wicked celebrations because we fix them. Alleviating poverty's impact on health. These are all types of things that design thinking is uniquely suited to work with. And you'll see how I phrased all those questions. One of the first things you can do to expand your horizons in your own work is to reframe your question with a how can we statement. So instead of saying, how do I reduce wait times for surgery, you can say, how can we increase access in general to needed procedures? It's a much more expansive question. So at the very beginning of a process, it's helpful to use expansive things that don't limit you. So I spoke about context and the importance of understanding where you are within your own system when we're looking at system design and system thinking and design thinking. And I thought it was important just to give this is going to be really, really quick. This is from a report called Mirror, Mirror, which is a little tongue-in-cheek and a little sarcastic when you see what is to come. Commonwealth Fund funds a lot of health research in our country and is a well-known source of good statistics. And this is a survey that they put together. It was a sample of 12 countries, nations that they believed were relatively similar in what you would expect. And I want to just show you where we are in the US. So first of all, talk about a wicked problem, healthcare costs. The cost of the United States healthcare system, absolutely considered a wicked problem. People don't even know where to begin to rein in these costs. It seems like everything that we've tried has been ineffective. And you'll see that we're up here. These are the 12 nations. I did put a little Irish flag for the stats that I could find on your country, just to give you a sense of where you are relative to others. So you see United States is way up there, over $10,000 per person spent on healthcare expenditures in the United States. The blue bar is always the comparable country average, so where they would expect the US to fall. So what could this mean? Well, you might think maybe we just have a lot more hospital beds. Maybe we have more healthcare. Oh, no, we don't. We're down there, 2.8 beds versus, well, Japan's way out there, so you can take out the outlier, but everyone else is somewhat in line. Maybe it means that we just stay in the hospital longer. No, it doesn't mean that either, because we're down at the bottom there. Ireland is low with us. Now, a low length of stay is not a bad thing necessarily, right? But you might think that we spend a lot more money because we stay in the hospital longer, and that's not true. So maybe it's just that we have so many physicians. Nope, we're near the bottom for that too. We don't have that many physicians practicing. In fact, we're expecting to be 90,000 short by the next 6 or 7 years. Maybe we just go to the doctor more often. Oh, no, we don't go to the doctor more often. There we are, second to last, 4 visits per person per year in a doctor's office. Then maybe it's just that we live longer. Nope, we're at the bottom. So this is a wicked problem. So the United States is spending more on healthcare than anyone, and by all accounts, we're getting a lot less for it. So there are so many questions that you could really generate from a health services research perspective. For comparable stats, you'll see the Irish flag is up there. So Ireland's doing much better. This is a very complex situation in the US. There's about 1.2 years on average of that in aggregate is due to gun violence. If you're an African American male, 4 years of that is due to gun violence. So definitely there's an effect of that. Take gun violence out of the equation and we're still at the bottom, but we're closer to everyone else. So then maybe you say, well, maybe we just don't get sick. Well, no, there we are, older adults with 3 or more chronic conditions. We're at the leaders and best right there. And then we also have the unfortunate situation of having the highest percentage of people who are not getting care or having problems getting care due to cost. So I give you that context just because I think it's an important context to know that the work that I'm doing in the US is full of wicked problems. Like, we really could spend 3 days in a workshop just focused on one of those, or one small piece of that, because the US system actually is a 50-state system, which runs like a 50-country system. It's not a system at all. And in some ways, when you see something that is supposed to be a system and it's not, that's a great opportunity to start with a design thinking framework, because design thinking and systems thinking actually are very analogous, and that's one of the reasons why it's such a great opportunity for our problems, because our system, so-called system, really isn't much of a system at all. So it's a good place to start. So there are many frameworks of design thinking. All of them are absolutely worth investigating. If one doesn't work for you, you can try a different one. There's a change management sort of nature to all of them. This is the Stanford D School, the most basic and most popular model that most people would use. So if you were learning this at a university, or you were taking a weekend course, or you were engaging this afternoon, you'll do pieces of this that starts with really gaining a deep understanding of the problem, the wicked problem, and the people impacted by it. So that's your empathize and define step. Then you spend time generating many, many different ideas to approach your problem in ideate. And then you keep narrowing that down. So you're starting very broad, you keep narrowing the funnel until you come up with some ideas that you can prototype and test. And what I'm going to show you, this is a very simplistic overview of it, but what I'm going to show you is how we use this. And I'm hoping that what I give you some ideas, that it will help you this afternoon to be able to apply to your own situation. So one of the things that my firm worked on with someone, this was with a funder, the Blue Cross Blue Shield of the state of Michigan. So we had a room like this, and it was a group of both the funding side of it as well as the delivery side of it. So it was people that ran clinics, people that worked on clinics, general practitioners, as well as people like you who are looking at the problems, and the funders. So what we were looking at is we were trying to get to how can we get hospitals and clinics, in our case, federally qualified healthcare centers is what they were called, so free or low-cost clinics. How can we get them to work better together and to solve problems together? And this was I'm taking you through one group's journey. And this particular group looked at young adults. And young adults in the United States tend to be one of our highest uninsured groups. And the reason for that is that they tend to be service workers. They work in jobs that don't offer health care. They have enough of an income that they don't qualify for subsidized health care, but they don't have enough income to actually buy health insurance, which is very expensive, and often doesn't actually cover most of what any preventive care would be. So the first thing that we did is we looked at all sorts of hypotheses. So why would young adults not be getting care in the right location? The right location being these clinics, right? We don't want them to go to the emergency department with problems that could be handled elsewhere. We want them to go to a more affordable source of care in a system that's designed for them, right? So the clinics are saying, we designed this system to make it easy for them, to make it accessible, but we're not getting the young adults. And young adults in this particular age group tend to be one of the highest need groups for addiction services, for mental health services. And this is actually one of the few places that they can get those services at a low cost. So the question just kept coming up, why are we not able to attract them to these services? So we looked at all of the data with them and tested some different assumptions, ran some different models to say maybe it's this, maybe it's that. And they had actually already tried to design some different campaigns, awareness campaigns, other types of things to get people into care, and it just wasn't working. So the decision was made, like, let's go deeper. We had young adults in the room, so people in this young 20s age group. And what they said, and a lot of which was predictable, but it's always good to hear and validate, was I can't take time off work. I don't have a salaried job. I have an hourly job. If I don't go to work, I don't get paid. So that was one thing. That, so in your mind, you're jumping to solutions. Well, we could do more hours. We could give them extended hours. We could open on the weekend. But the idea here is that just allow people to express themselves and give yourself a chance to deeply understand where they're coming from. The other thing they said is, well, I go to the emergency department because I know I can get everything there in one stop. I know I can get my x-ray, I know I can leave with the medications I need, and it's just much more convenient. So I'm going to continue to use the emergency department. Other young people said, well, I don't actually ever get sick. So it doesn't matter how many times you tell me you're there, I'm not going until I'm sick. I'm not really interested in preventive care at my age. And then others said, it's really expensive when I go to see a primary care physician. In the United States, if you go to the emergency department, you will receive care, whether you can pay for it or not. That is not true at our general practitioners or our primary care services. You have to pay to use them. So most people without insurance will go to the emergency department. So that was another thing they wanted to try to solve. So you go deeper and deeper, and the idea is that if you had a kaleidoscope and all of these young people were in it and all the services were in it and the funds and the insurance and the jobs, and you turned it, every time you turned it, you would see it from a different perspective. And you'd see all the same components, but it would all be rearranged and allow you to see something differently. So the idea, as you do this empathize step and you try to define it and go deeper, is to just continuously see the problem in a different context. And hopefully that you can think about your own work and think about how if you looked at all the components of your work through a kaleidoscope, every time you turned it, you would be able to get a new insight. You would see something different than what you had seen before. What happened with this work, and this one actually is with an app developer, and they're taking it from pilot into designing it into a real solution, is that the access problems that we thought were there were definitely there. Financing was an issue. But really, they wanted to zero in on the overuse, underuse situation, meaning that people who were using it, who were seeking care, were seeking it in the wrong place. And people who needed care were underusing it, ironically. So this is what they came up with. Now I'll go to this side since I'm always on that side. So some people want to use the emergency department. Some people want to use minute clinics. Those are in our pharmacies. They're just walk-in care for a low cost. Some people want a telehealth solution, and they want it on their mobile phone, and they want it done in a certain way. And then this is a mobile van. So many communities, especially our safety net or our poorer communities, will have a mobile clinic. Now, all of these solutions had been tried. And so the group was a bit perplexed by these young people and said, but we've offered you all of these things. And what they said was fascinating. It's not that we want all of these in one way. We want to be able to choose, and we want to do it in real time. And what I want on Monday might be different than what I want on Wednesday. And I just want all the information. I don't need you to give me one solution and expect me to use it. I want you to give me all of the information I need to make the right decision for me. So what they came up with is this app that is used sort of like Snapchat. I'm not a Snapchat user. I don't really understand Snapchat. What my kids tell me, though, is wherever they are in the world, their Snapchat filters come on and give them all sorts of information about where they are, where to buy coffee, where to do all sorts of things. And so some of the young people that were part of this said, I want it to be just like Snapchat. I want the information pushed to me. I don't want to have to go look for it. So what you see here is an app that on any given day, at any given time, you could look at and see all of the options available to you in all of these different formats where you could seek care. So the idea being that no one has to commit to one way for any extended amount of time. And this could be funded regionally, which is what this Blue Cross decision was, to try to do this regionally and offer these young adults this option. So the idea is that without talking to them and without really understanding why it was that none of these solutions on their own were what they wanted, we would have never gotten to a solution like this. And we were able to prototype different things and understand these filters and approach some of those companies and say, hey, you already have this filter thing set up. Could we just use some of that technology? On to a second example. This is not your children's hospital situation. However, I do have a lot of experience in that line of work. A lot of what my company does is actually envisioning future facilities and scoping them and choosing locations and all of that type of work. So it's been fascinating to be here this week and to read all about your situation, which is actually not as unique as you might think or as we might hope. But to watch the way it plays out politically is always interesting, right? As somebody who likes to study different contexts. So if anyone wants to chat me up about that later, I'd love to hear your take on it. This is a Canadian example. We do a lot of work in Canada. I'm not actually sure why. Some people say, why does your company do so well in Canada? I think part of it is we're public health people. And Canada has a very public health focused system. So we tend to really enjoy working there. I feel like Canadians tend to come up with really innovative, great ideas that if you took America's financing and Canada's ideas, we would have a really fantastic system. Because they come up with really, really innovative solutions that are very people-focused. Then where they tend to fall short is on the financing to actually get it implemented quickly. So we were working with a children's hospital in Canada, and this hospital, we're doing a whole redevelopment project. So it was redevelopment of all of their service lines. But the one I'm going to share with you is something that we did with the emergency department. When we do design thinking, it's often in a room like this, and say you are the emergency department, and you might be surgery, and you might be inpatient. And it's a very loud, chaotic scene, which maybe we'll recreate this afternoon. But always very interesting, and this was done with the emergency department. We started all together in a room like this, and then we took it further with them over a series of months. But their situation was a bit unique in that their crowding was not necessarily due to a lack of efficiency. They actually had a very efficient system. But even with a very efficient system, you can't put 1,000 people through a space built for 200. So what they were trying to do is they wanted to figure out a way to better serve their customers, their patients. And when we did the observation and we pulled all the data, and we started from the obvious descriptions of the challenge. So it's loud, it's chaotic, it's unpleasant. There are screaming children, of course, because it's an emergency department of kids. There are long waits. There was a triage and prioritization problem. People always wondering, why did that person go first? Why they don't look sicker than I do? And then there were non-emergencies in the queue, so people who were there because this is the only place they could get pediatric-specific care, although they weren't to the emergency level of the threshold. And then, of course, boarding. So they, like everyone else in almost every country, I believe, have many kids sitting in the emergency department waiting for a bed somewhere, whether it's in a children's hospital or in a mental health facility. In the US, that tends to be our largest segment of boarders is people, adolescents waiting for mental health care. We don't have very many resources for that. So when we went deeper and we observed, always a enlightening part of the experience. So we put a whole team in there to observe the emergency department at all hours, at all shifts, all days of the week. And we tried to look at the problem again, turn it through the kaleidoscope and look at it in different ways. And what we found is that part of the reason that they were so challenged is because they were so good. That's often the case with leading hospitals, especially children's hospitals. They just attract so many people that they have trouble keeping up with them. So in addition to that, though, they had people that had traveled a long distance, so they really needed everything done in one visit, and people that were using it to jump the line. So I'm sure you experienced that here too. So people who were on a waiting list for something and just felt like they couldn't wait any longer, so they come to the emergency department with hopes of getting that service. Then there were people that needed procedures and were waiting, so they were taking up a bed waiting for a procedure, as well as the other ones that I spoke of. So one of the things that we did when we generated all the ideas, so we had hundreds of ideas over several days that we were evaluating. And this is a tip if you're ever stuck in your research or in defining your research questions, especially, this is helpful. We developed these continuums, and we had about 50 of these. These are some examples. But when people wanted to generate all sorts of ideas, and we sometimes we'll call them solutions, but oftentimes we call them ideas because they feel like there's less pressure associated with them. An idea has yet to be developed. We haven't invested in ideas yet. So what we encourage people to do is come up with these continuums. And in this case, we tested every idea to say, does it work equally well on both sides of the continuum? Because in emergency department, oftentimes we'll have a great solution that only works at peak. And then in the middle of the night, it doesn't work as well. Or on a Saturday, it doesn't work as well. So for every one of these, we developed continuums to measure and say, does this idea work in all settings? Again, always go to your specific context. We're looking at the structure, we're looking at the process, and how it impacts the outcome within a specific context. So from there, we then were able to pilot some different solutions and really focused on the fact that data is one input. So we had lots of data. We were able to take data, we were able to take our ideas and to overlay it and say, how would this have worked on the busiest day last year? How would this have worked on the slowest day last year? And we would run our simulations and test these ideas to decide what we wanted to pilot in real life. What we ended up doing there is we took the department and we segmented it. And we said, the first split is going to be, are you actually here for an emergency? And that is a role of triage, of course. But we were actually going to do this pre-triage to give people a chance to self-select into a different model of care. So we had an evaluation center that was able to kind of funnel people into what they needed. So if they needed a medication refill, if they needed access to other services for non-emergencies, and then emergency care had its own section. And that actually was very helpful. You need space to do that, of course, but that was very helpful to make that the first segment. And part of that, and the reason I tell you this one, is in part of the challenge there was not that, it wasn't that people didn't know that they weren't in an urgent, emergent situation, but they didn't know what other options were available. So this is where we call this fostering affordances, because sometimes we expect people to know how to use our systems. And we expect just that people know things. And one of the great things about design thinking is it allows you to go deeper and ask, what is it that we're expecting people to know? And how will we know if they know those things? And the emergency department is a really great place to start and to study, because if you ask people questions about why they're there, oftentimes you'll figure out that they actually have no idea how to use your system. And they don't know. You might have a kiosk that you're wondering, why is no one using our check-in kiosk? Well, it might be because they have no idea that they're supposed to use it. Or they have no idea what it does, or that they're supposed to use it. Sometimes when people approach a kiosk, they think that you have to be a member, you have to be pre-registered, things like that. So to take a step back and ask ourselves, what is it that we expect people to know? And are we guiding them adequately? Because people can't use the system if we don't teach them how. And design thinking allows you to kind of flip the model a bit. So instead of focusing so much on what you're providing, focus on what people are getting. Instead of focusing so much on what you're saying, focus on what people are hearing. And it's often a mismatch. And aligning those things can be the first start of a great solution. So the next thing that we often look at is false boundaries. So these are tips on what to do if you're a little bit stuck when you're using design thinking or any kind of innovation work. You can do that first one, which allows you to ask different questions. And then the second one, you can say, what are the false boundaries? And this is also a good place to ask that question of what goes on here. So what's really happening here? And a false boundary, an example of that would be, yesterday I used a HEMONC example that I think is a fairly good one. So when we set up different hematology oncology programs, which I spend a lot of my time working in cancer care, we often have this divide between inpatient and outpatient services. And with HEMONC, it tends to be a little more fluid, because sometimes especially with kids, they show up for their treatment and they don't make their counts and they end up in inpatient. And it's very disruptive to the system because it's hard to adjust and it's hard to find a bed when a child needs something more than the infusion that they were scheduled for that day. Well, if you were to take that boundary completely away and say, how do we design care around kids who we know have cancer, but we don't know how they're going to be that day, the day that they walk in, you end up with a different system. Because the first question that people have, again, how do they know how to use your system, when you arrive in the morning, is you've already told them they're either going to a clinic or they're going to an inpatient unit. Well, for a cancer kid, they're often ending up someplace that they weren't intending to go. So what if we designed a system that instead of feeling like you have failed, you failed your counts, you can't get treatment today because your counts failed. What if we designed a system where we didn't have to make people feel that way, and instead we were just meeting the patient where they are on that day? Whatever your condition is that day, this is the day that we want to see you, we're going to check in with you, and we're going to give you whatever you need. So that would be an example of saying, for your own work, what if we remove boundaries? Where are my false boundaries? Where are the places that we draw lines that are arbitrary, that we've decided? You know, sometimes the system problems are of our own making because we created some false dichotomy. So the third one, and this is the last one, and this is often the most fun, as well as the easiest. So for those of you in the room who help others do this thinking or help others think about their research or their research questions or how to design an experiment or get someone to participate who may be reluctant to participate either in a process like this or in research, you look up and you look out and you find connections to things that are seemingly unrelated. So you would say, how would a leading company do this? You think about the best experiences that you have. This is always a very safe way to do any kind of exercise. You can't get people to talk, ask them about the best hotel experience they've ever had. Ask them about going to Disney World and what was the best and most delightful thing that happened to them. Get them talking about something that they loved, and then draw the analogy. And then say, well, how could we create that surprise and delight in healthcare? How could we make that happen for you when you come to see us? How could we make your wait more bearable? You waited in line at Disney World. You didn't hate the trip. What was different? So that's what the analogous thinking part is about. And this slide has a very American context, but I've been assured that it will work equally well here. I hope that's true. So this is our fallback. So in my company, when we design solutions for people or when we try to help people to think outside of the box, if you will, we tend not to use that framework, but that is really what we're trying to get them to do, is try to just think differently and put yourself in a different context and understand it in a different way. Again, turning the kaleidoscope. We'll often test our own solutions before we bring them to the client, and we will ask, are they good enough? Are they interesting enough? Have we done anything for the client that they couldn't have done themselves? Have we worked with that health system or that policy group? Have we shared anything with them that if they had taken the same amount of time that we had, they would have not come up with? I mean, that's value, right? We want to deliver something that someone could not do themselves. And this is what we use. We say, does our solution meet the quality standards that Intel would have? So Intel being the chip inside your computer, they have very specific standards of how those chips are made and who can touch them and how you touch them, and they're done in a clean room. Like, have we taken that level of care? Does it have the consistency of Starbucks? Meaning, if I implemented my solution with you and with you and with you back there, would it work the same way? Can we count on the results? Do we have that level of consistency? Is it the innovation of Tesla? So, have many of you driven a Tesla? Raise your hand. Okay, if you get the chance to drive a Tesla, drive a Tesla. I'm not a car person, and I don't really care about cars, honestly. But when I drove a Tesla, all of a sudden I cared about cars. So it's a car that gets you to care about cars. It's fun, it's interesting, it's different. You get in there are no controls. It's all on a screen. I mean, it's a completely different experience. And that's what we want people to have when they work with us. We want people to walk away saying, wow, that's not what I expected. That's so much more than I just paid for. That's how I felt when I got into Tesla. And that's when I took back to my team, I'm like, we need to be like that. Like, we need to be that good. And then we say, do they have the reliability of FedEx? So FedEx being our shipping company, they would probably not drop your bike, by the way. And they would get it to you exactly on time, almost to the minute on your app. They will tell you exactly what you're getting when you're getting it. And we want our solutions to be that reliable. We want people to know if you invest, if you actually implement this solution, because implementation is where people fall down. People don't have a lack of ideas. They have a lack of will to implement. So we want it to be as reliable as FedEx. And then does it have the convenience of Amazon? We need to create solutions that are the path of least resistance. In that emergency department in Canada, we, instead of fighting the way that human nature was taking people down this path for emergency services, we said we're going to give them what makes the most sense and what's the path of least resistance. And that's the ease of Amazon. The Nordstrom example, that's just a high-end department store. So even if you're not doing something luxurious, there's no reason you can't make people feel like you care about them in the same way that a luxury brand would. And then finally, and this is the most challenging, is can we do it at the price of Walmart? And the important thing about the price of Walmart is not actually about the price point. It's about, can you deliver what you're trying to do? Can you deliver your solution at a price point that is affordable to the person who needs it? And that's really where the Walmart example comes in. It's not, can you be the cheapest on the block? It's not about the lowest bidder or the lowest tender. It's, can you deliver what people need at the price point that they're willing to pay? And if ever you're stuck, create your own version of this, and it's a great litmus test to see, have you really pushed beyond your own limits to think about something completely different or think about it differently so that you can deliver it differently? And I hope that was helpful to you. Thank you so much.